Good evening, everyone. We'll be starting the webinar in another 5-7 minutes. Thank you for joining us for yet another session.
Yeah, hi, good afternoon.
Good afternoon, sir. Sir, we're not able to see your video.
Oh, just 1 second. Is it okay now?
Yes, sir.
So,
So
all
we'll
set?
start. Yeah. Good evening and a warm welcome from Krista team. Thank you all for taking the time to attend today's webinar titled Male Infertility, Diagnostic and Clinical Perspective. I am Shinka Arora and I will be the moderator for today. Before I introduce our speaker for the day, I would like to introduce Krista. Krista is the mother and child healthcare brand of Redcliffe Life Sciences. It is a complete online reproductive health platform providing all services for fertility and pregnancy, starting from diagnostic tests, advanced genetic tests, counseling services, and doctor consultations, all easily accessed through Krista's online module. So without further ado, I would like to introduce our honorable speaker for the evening, Dr. Sarabpreet Singh, who is a senior consultant, Department of Reproductive Medicine at Artemis Hospital. He is also consultant for male infertility at Krista. Before we start the webinar for today, I would request everybody to please answer a few upcoming questions. All the questions will be available for 30 seconds each. Please log in your questions.
Shrinka, when do we start?
We'll just as soon as the poll finishes, we'll start, sir. Yes, I'll give you the cue for that.
Something seems to be wrong with my connection. I don't know.
Please log in your answers for the second question of the poll. Which of the following can cause problems with male fertility? Moving on to the third question. Which of the following lifestyle habits may cause problems with male fertility? Please log in your answers for another question. Which of the following do you know that consuming protein shakes may lead to male infertility?
Sorry, I lost my connection.
No problem, sir.
Is it okay now?
Yes, sir.
उसमें कुछ लगा ही हुआ.
No problem, sir.
So when do we start? Is your poll over?
Almost.
Okay, do it.
Okay, sir. We are done with the poll.
Okay. So
Yes,
can you share
over
the
to you.
slides now?
Yes, sir. I'm sharing. Yes, sir. Over to you.
Is there any slide share option? Can we enlarge the slides, or this is going to be the size?
Yes, sir. Actually, everybody can see a full page slide here.
Okay. But I can't actually, so I was just wondering.
No problem, sir.
Anyway, so
Go ahead, sir.
yeah, just give me a minute.
Yeah.
Yeah. Shrinka, shall we start now?
Yes, sir. Please go ahead.
Yeah. So the topic for the day is male infertility, and I'm Dr. Sarabpreet. I'm a senior consultant at Artemis Hospital. I'm going to present this topic, and we're going to focus on diagnostic as well as we'll touch upon the treatment part of it as well. The definition for infertility is the ability of a couple to become. It's the inability of a couple to become pregnant after 1 year of unprotected intercourse. It can be either primary or secondary. Primary is when the patient has not conceived even once, and secondary is that they have conceived, but now they are unable to conceive further on. Like today, I met a patient. He has a daughter, but he cannot conceive once. He has a daughter, and now he cannot conceive. His counts have gone down. So that is a case of secondary infertility. So why do we need to focus on male infertility? Because in generally, in our observation, we have seen that the male partner is usually ignored. In earlier days, even a semen analysis was done as the last test. Probably there was no attention on male infertility. The males were presumed to be perfectly fine and okay, and in case any test was required, it was the last test. We generally, even now, the history is not taken properly. There is hardly any examination. So many cases can be resolved by proper examination and history in case the male is evaluated. So we must have a protocol to evaluate the males along with the females. But why is there so much of concern about male infertility? It's a social stigma like female infertility or like infertility in general. It's a social stigma, and it hurts a man's ego all the more, if somebody is labeled infertile or even sub-fertile for that matter. The prevalence of male infertility is it is solely responsible for around 20 to 30% of infertile cases, and it contributes to almost 30 to 40% in most of the couples. So it can contribute to almost 60% of causes in case of couples. We have seen that the azoospermia is almost present in 1% of the total population and around 10 to 15% of infertile men. So both male and female should be involved in all the counseling as well as the evaluation of infertility. This article in I think it was in Gulf News some couple of years ago in 2017, and it was a very it was a very sensational article. It said that a sperm drop could make humans extinct. It is one of the news which came up, and it reported that there is a 50% decline in sperm concentration over the last 40 years in North America, Europe, and Australia. Obviously, Asian and African countries were not considered. But then even in the developed world, we have got a major decline in the sperm concentration. So imagine third world countries and other Asian countries. You can imagine the extent of damage it's done in these countries. Anyway, my animation is not working because of the slide share, I think. So, but I'll come to the point straight away. Infertile males have a much higher incidence of familial and individual cancer. Notably ALL, thyroid cancer, melanoma, obviously testicular cancer being there. And in such cancer patients, usually we have seen that the sperm concentration is very poor. Recently, we have started the process of fertility preservation, in which we preserve the gametes of males having testicular cancers or any other cancer, because once the chemotherapy or radiotherapy starts, the counts are anyway going to go down. So it is better to preserve their samples before the treatment is started. That's like a saving grace, but yes, male infertility is associated with the cancers also. So this point has to be remembered. And also to remember is that fertility preservation is a very viable option, and the person can conceive once he's fine. If he's a young guy, he becomes all right after his chemotherapy and radiotherapy, then at least he can think of planning his family if he has got sperm preserved at IRT center. So coming to the symptoms of male infertility, generally there are no symptoms for any infertile problem. The patient will come with an inability to conceive. Intercourse, erection, ejaculation is generally normal in such patients. But at times the patients do present with sexual dysfunction such as ejaculatory disorder and erectile dysfunction. They might complain of a lump or pain in the testicular area. They might complain of recurrent respiratory infections, which again, raises some kind of ignites a spark in your brain that it might be a case of Carcinoid syndrome. He may present with inability to smell, which indicates towards a Kalman syndrome. There might be abnormal breast growth or gynecomastia, which may point out towards any endocrine disorder. Decreased facial hair, again an endocrine disorder or a genetic cause may be the reason for these developments. When this person is evaluated, he often presents with a low sperm count. So the point is that where have all the cowboys gone? Why is the incidence rising day by day? Gone are the days when we used to see men with accounts like 200 million and 250 million. Now even if we see something like a 40 or 60 million, we label the male as very fertile. So the reasons primarily responsible are along with the factors like age. With age, always the counts in motility decrease, which will come to this point later on. But lifestyle factors such as obesity, tight underwears, exposure to toxins, heavy metals, cell phone usage, electromagnetic radiation, drugs, heavy metals, smoking, alcohol, laptops, sauna baths, hot water tubs, they are all detrimental to our testes, and they raise the temperature of testes, and ultimately leading to men suffering from sub-fertility and infertility. An X-ray radiation of more than 6 gyron can permanently make a man azoospermic. he'll be a sterile person thereon. Whereas a radiation in the dose of 0.015 gyron can decrease somatogenesis. Coming to obesity, for every 5 units increase in BMI, there is a 2.4% fall in sperm count and 2% fall in sperm volume. It interferes with the basic hormone axis, which is the hypothalamo-pituitary gonadal axis, and it results in loss of libido, erectile dysfunction due to low endogenous testosterone levels. Treatment is mainly lifestyle changes such as diet, exercise, behavior. Along with, we can offer him pharmacological interventions such as appetite suppressants, weight loss drugs, or surgical options are there such as bariatric surgery. And if nothing happens, then ART option is always there for such patients. The primary, if you look at the distribution of male infertility, generally it is idiopathic. And why this is most common? Because the male was born perfectly normal. He looks phenotypically normal. Genetics are all normal, but due to lifestyle changes, which we have just seen, these lifestyle changes, now he has become an infertile male because of raised scrotal temperature and sperm count going down. Mal-descended testis, which was not identified in early childhood, and it could not be fixed by 2 years of age, so it is again contributing. Urogenital infection, varicocele again is very common, which we'll discuss later on. Hypogonadism, which can be endocrine or otherwise also. So these are the main causes of male infertility. How do you evaluate a person who is presenting with complaints of the couple not being able to conceive? We need to identify this person. We have to identify the cause and correct the cause. We have to identify the patients who can be offered intrauterine insemination and IVF ICSI. We have to identify individuals with genetic abnormality, because until you identify, it will be difficult for us to understand the reason for infertility, and we have to counsel the patient about the future offspring inheriting the genetic abnormalities, and further on problems can be there in conception for the kid also. We have to identify the patients with donor sperm and counsel them for adoption or either donor sperm. And we have to identify underlying medical conditions which contribute to infertility, such as even diabetes, hypertension. All these medical conditions contribute to infertility. So when I talk of history, we have to take fertility history, which includes duration of marriage and infertility, past conception, if any, previous fertility investigation, treatment. We have to take a detailed sexual history such as frequency of intercourse, libido, erectile dysfunction, ejaculation, any use of lubricants. So if they're using lubricants are generally gametotoxic. So you stop the use of lubricants and the patient might just conceive. We have to take medical history such as diabetes, hypertension, respiratory tract disease, as there are conditions in which the respiratory diseases are associated with poor sperm motility or no sperm motility at all. Such conditions can be identified if the person complains of respiratory tract disease. You have to take history for neurological diseases, any high fever, because high fever can also contribute to poor counts. Any history of any medication and duration of its use, history of urinary tract infections. When we talk of surgical history, we have to take history for varicocelectomy, hydrocelectomy, and surgery for hypospadias, epispadias, hernia, hydrocele. All these history has to be taken. Then you have to evaluate the person for any childhood history of mumps, viral illness, scrotal injury, testicular torsion. So these things are important, and the profession of the person has to be asked for occupational environmental history, and we have to see if there is any exposure to heat, toxins, radiation. The person might be an X-ray technician and suffering from infertility. These things are quite common. We see them very often in our hospital staff also. The patient might be exposed to carcinogenic dyes, tannins. Substance abuse is also very important. It has to be evaluated. It leads to decreased counts, especially in people suffering from opioid addiction and other substances also. Then a family history of infertility has to be evaluated. any chemotherapy, tobacco, alcohol, smoking, like I explained in the previous slide also, these things have to be reported, and we have to counsel the patient to give up on smoking, alcohol, and tobacco. Another thing I wanted to address was the age, because we have a lot of patients coming in elderly age group, and these patients generally come with decreased volume, and even the motility is less, concentration is less. So that is nothing unusual, because semen volume decreases by almost 0.03 ml per year, and motility also decreases by 0.7% per year. Anybody who has gone for a IVF treatment will understand these terms. Anybody who is not familiar with these terms can simply after the lecture they can go and search Google for this. So the volume, motility, as well as concentration decreases. Even morphologically normal sperm proportion decreases. There is a term known as ADAM, or androgen deficiency in aging male. In this, there is a decrease in the total serum total and free testosterone levels. There is a decrease in sex hormone binding globulin. So free levels decrease more than total. Once the free levels decrease, so even the total hormone levels are normal, still the drug, still the hormone will not be able to act. So the treatment for ADAM is when total testosterone is less than 200 nanograms per DL, then we have to start with testosterone therapy in the form of IV drugs, or we can give pellets, gel, patches. There's a term known as andropause, which is the counterpart of menopause, but it's not as common, you can say, or not as severe, you can say. The diagnosis is by evaluation by morning levels of total serum testosterone, and free testosterone index has to be calculated. Usually it presents with low sex drive, difficulty getting erections, lack of energy, depression, irritability, mood swings, and there is loss of strength or muscle mass. You can give testosterone injections, but generally it is not recommended if the patient is from an elderly age group. Examination again is very important. You should refer to a urologist or an endocrinologist, and general examination for secondary sexual characteristics is important. Genital examination has to be done, so the patient has to be referred to a urologist or an andrologist, preferably. When you examine the scrotum, you have to rule out varicocele, hydrocele hernia. Epididymis and vasa have to be palpated, and it feels like a spaghetti-like or a cord-like structure. Testicular volume can be calculated with the orchidometer or ultrasound. Simple ultrasound can also give it testicular volume. Hypospadias, it's again abnormal urethral opening. Hypospadias and epispadias, they have to be ruled out because sperm might not be deposited in the right area in the vagina, and so conception becomes difficult. Prostatic size has to be evaluated with the help of a peer examination. Normal testicular volume generally ranges between 12 to 30 ml. So it has to be in that range. The figure on the left shows an orchidometer. Semen analysis. I'm sorry, this slide is not working. I was trying to show you how normal semen looks like. Can you play this slide from there?
No, sir, there is no.
No, you can't play. It's a small video, actually. No, you can't play.
No, sir, these are just his
Doesn't
slides.
matter.
Yeah.
So when we talk of normal zoospermia, as per the WHO 2010 guidelines, volume should be 1.5 ml. pH should be more than or equal to 7.2. Sperm concentration should be 15 million per ml. Total sperm number should be 39 million per ml. Total motility should be 40, and progressive motility should be 32. Strict morphology, when we talk of normal forms, it should be more than or equal to 4. Men with semen variables, this line is an important line. Men with semen variables outside the reference ranges may be fertile, and conversely, men having values within the reference range may be infertile. So what this means is that there is no man who can be labeled as infertile. So we can label him sub-fertile, and these are arbitrary values which we think, or WHO has prescribed for as a cutoff to label oligozoospermia or reduced counts, reduced motility. But generally, this is not the cutoff. People with counts lower than this, motility lower than this, can conceive naturally, and vice versa also. So oligospermia is when we have counts less than 15 million, asthenozoospermia when we have motility less than 40%, teratozoospermia when the morphology or the normal forms is less than 4%, and there is a term known as OAT syndrome, which is a combination of oligo, astheno, and teratozoospermia, in which you have less count, low counts, low motility, and abnormal forms. Azoospermia is a condition in which we don't see any sperm after a thorough lab evaluation. Asthenozoospermia, in which we have low motility, can be because of infection, it can be because of varicocele, prolonged abstinence. If we don't ejaculate, if the person doesn't ejaculate for long, then obviously the dead sperms increase and the motility goes down. In cases of vasectomy, reversal, or anti-sperm antibodies may be formed, which make the sperms, the sperms kind of club to each other and they don't move. So all these things can contribute to asthenozoospermia. When we talk about azoospermia, which we'll discuss in detail later on, the definition is that no sperm is seen in semen sample even after centrifugation for 15 minutes at a very high speed. There is another condition which is even which I feel as a person dealing with male factor and embryology is even worse than azoospermia. It is cryptozoospermia, in which is technically defined as around 1,000 sperms per ml. So in this, after centrifugation, you will find one odd sperm, and even when you explore the testes through biopsy or aspiration, you will hardly find any sperm. So this has got even a poorer prognosis compared to a person presenting with pure azoospermia. So when you look at the spectrum, severe oligospermia is less than 5 million, you can say. Crypto is less than 1,000 sperm after centrifugation, and azoospermia is absent sperm. So these are the general instructions which we give to the patient or which we counsel the patient for. 2 to 3 tests should be done 1 month apart with semen parameters within 20% of each other. Abstinence recommended by WHO is 2 to 7 days, but we generally recommend 3 to 4 days. The whole of ejaculate should be collected. Initial ejaculate is very important because it has got the highest concentration of motile sperm. No condoms, or even non-toxic condoms should be used for collection. No home collection, no coitus interruptus. Only masturbation is recommended, although there are reports that because of masturbation, counts may go down because there is a negligible sexual arousal. But in case of natural intercourse, the counts may go up. But that is something which we can't really help. Analysis should be done within 1 hour. So we are discussing semen analysis for so long because this is the cornerstone of male infertility evaluation. It's one of the most controversial tests, as it is something which can label the cutoff values hold no good in almost 5% of the patients, whereas in 90-95% of the patients they do have some meaning. It is an inexpensive test. It looks very simple and easy, but it's actually very difficult to train a technician and make him report the sample in a nice fashion. It is said that it is very easy to do this test badly, and if you believe me, I mean, I've been working in this field for 11 years. I've seen funny reports from most of the highly renowned pathology centers, which I would not like to name now. One reason for the semen analysis being a very non-specific and a controversial test is that these are slides from WHO. See that a person who has 300 million count on one instance, this is over a period of 540 days, almost 1.5 to 2 years. See how the counts are fluctuating. And in look at this patient. In this, the count has gone up to 250 million. On one occasion, he has reported a 0 count. So counts do fluctuate, and a lot of factors are responsible. Sexual arousal being one of them. Person's mental state, history of fever. So many factors play a role, such as the sample may be complete or incomplete. Like I told you, the initial fraction is important. Sexual abstinence again is important, or long abstinence will decrease the motility, whereas the short abstinence will decrease the volume and concentration. Method of collection I've explained already. Testicular size is proportional to spermatogenic activity and affects sperm morphology. Fever, a history of fever in the last 2 months can lead to decreased counts and even azoospermia, because it affects the sperm in a phase when the sperms are dividing. So the sperm concentration can momentarily go down to almost low, so severe oligospermia or even azoospermia. Another terminology that I would like to introduce is the concept of sperm morphology or normal forms. A sperm has got a head, midpiece, tail, and on that there is an acrosome, which is very important for the process of fertilization, which results in a baby. So these things have to be evaluated, and morphology has the greatest discriminatory power in terms of fertilization, and all morphology is even a greater discriminator compared to normal concentration and motility. It identifies couples at risk of poor or failed fertilization with the standard use of in vitro fertilization, and it helps in deciding IVF versus ICSI. If the morphology is very low, we will preferably go for a technique known as ICSI, which is intracytoplasmic sperm injection. In this technique, we directly enter the oocyte and just leave a sperm there. Whereas in IVF, we keep this egg and sperm together outside the body in a dish, and then we allow the sperm to fertilize the ova or the egg. Look how the WHO reference values have changed over so many years. If you look at the 2010 and compare it with 1999, there is a drop in volume, there is a drop in the concentration, there is a drop in motility, progressive as well as vitality. Everything has dropped. Morphology has gone down from 14 to 4%. One thing which has not changed is the total sperm count. Earlier it was 40 million total sperm count, now it is 39 million. So many authors believe that total sperm count is a better indicator of severity of male factor infertility than the WHO sperm classification system. So if you have got a nice total sperm count, the volume is more than it can compensate for a low concentration and low motility. So all the things have to be comprehensively understood. The sperm concentration, sperm volume, sperm motility, sperm DNA status, which will come to later on. So everything has it's a wholesome picture. One thing in isolation will not help you evaluate the male infertility. There is a lot of emotional angle to a low sperm count. Suppose you're meeting a patient in the car and you can hardly see a sperm, but still, I don't think it makes any sense for you to tell the patient then that you're infertile and the chances of conception are zero. Even in the cases of azoospermia, we can use testicular sperm and the patient can conceive. Even for that matter, cryptozoospermia, azoospermia, all the patients can conceive now with the advent of a technique known as ICSI or intracytoplasmic sperm injection, in which we require just one sperm to fertilize one ova. Volume of sperm semen is also important. Generally, it is 1.5 to 2 ml and is normal, and in aspermia there is no sperm, the volume is zero. Hypospermia is less than 0.5 ml, and it is generally seen in ejaculatory duct obstruction, seminal or Bass malformations, and retrograde ejaculation. Hyperspermia is more than 6 ml. It can lead to sperm dilution. Usually, it is seen in when there is an inflammation or infection of the accessory glands of reproductive system. Low volume is important because low volume can make you think about a few diagnoses. One of them is retrograde ejaculation, in which the semen, instead of coming forward, it goes backward into the bladder. So we have to collect the urine sample post-orgasm or post-masturbation. You collect the urine sample and then we process it for an IUI or IVF or ICSI, whatever the treatment is required, depending on the count retrieved in the post-wash, in the or post-masturbation urine sample. There is a way of processing the sample which is out of the scope of this presentation. Also, low volume can also be due to a duct obstruction. Again, we'll discuss that later on. pH is something which is again which is neglected, but pH has got great importance, and it indicates, in case of an alkaline pH, it indicates infection, whereas in case or if the pH is acidic, then it indicates obstruction of ejaculatory duct. Sperm vitality, I was thinking of leaving this topic, but then sperm vitality is the number of viable sperm. A dead sperm may be immotile, as well as live sperm may be immotile. But we have to differentiate the immotile dead from immotile live sperm. So there are tests which help us in differentiating between an immotile dead versus an immotile live sperm. And immotile live sperm can be used to fertilize an ovum or an egg, and ICSI can be done with it. So we have got a lot of children which have been born out of immotile live sperm. Motility can be induced, or other tests can be run real time to differentiate between live and dead sperm. One of them is a horse test or a hyposmotic swelling test, in which the tails curl, and when the tails curl, you can use those sperm for ICSI. We can add pentoxifylline, which makes these immotile sperms move if they are live. So there is a lot of hope for people with the low vitality. A term which I would like to just touch upon here, we'll come to this later, is the sperm DNA fragmentation index. DNA, as you all must be knowing, is the double stranded structure in which the whole genetic information is passed through DNA. So the integrity of DNA is very important. If there is a DNA damage, then it can result in infertility, birth defects, recurrent implantation failure, a very poor outcome of IVF and ICSI. So, and routine semen analysis does not give us any idea about the DNA fragmentation. So this test is gaining importance, although it's not a routine test till now. Now you have evaluated the male. Now you know the concentration, you know the total motile count, you know morphology, and you've seen the percentage of viable sperm through a horse test, and you know the DFI. Now these are the factors. In earlier years, it was only concentration and motility and morphology, but now we have added vitality as well as the DNA fragmentation index, and these are the 5 factors which help us in deciding the next step of treatment. And in case the concentration is more than 10 million per ml, we can think of intrauterine insemination. In case the concentration is 1 to 10 million, then we can think of IVF or in vitro fertilization, in which I think I should explain IUI also. In IUI, it's more like a natural process in which we prepare the semen, remove all the debris and the prostaglandins and other harmful factors, and we insert the semen directly in the uterus of the female, and then everything happens naturally after that. In this, the total motile count has to be more than 5 million. IVF is a process in which we take a dish, we keep 4 to 5 eggs in that, and we add semen. And with the help of sperm motility, the eggs can be fertilized. In this, we need at least more than 5 million count. ICSI is recommended when the counts are generally low, less than 1 million per ml. And nowadays, the concept of DNA fragmentation index has been added. IUI has to be considered only in cases with less than 15% DNA fragmentation. 15 to 30% we can think of IVF. When it is more than 30%, we have to go for a ICSI. And in case it is more than 60%, we have to go for a testicular sperm. I'll just take a break. The indications for donor sperm. Generally, as a lab, we discourage the patient who are going for donor sperm, because even in cases of azoospermia, we have to investigate thoroughly, and generally in almost 90% of the patients, we do get sperm with the help of techniques like microtessay and other advanced sperm retrieval techniques. So in case we don't get any sperm, then we counsel the patient for a donor sperm or child adoption. Immunological factors which are not correctable, patients have to be conscious. If there is a genetic disease in the husband, and the husband is not willing to pass on, there is always a risk of passing it to the child or to the offspring. So the patients themselves, they opt for a donor sperm. Artificial insemination is usually done in cases of oligozoospermia, in which count is low, asthenozoospermia, in which motility is low, but when we process the sample, the motility increases. We have got means to do that. Premature retrograde ejaculation, the patient is unable to ejaculate, and we have got sperm autoantibodies, cervical factors, unexplained infertility. These are the cases in which we have to go for artificial insemination. In even HIV positive patients, if we prepare the sample in the lab, we can take care of the HIV virus, and it is unable to permeate through the processing techniques, and the viral load decreases to non-infectious levels. So, what are the endocrine investigations which have to be done in cases of infertile males? Usually, when the patient is presenting with abnormal semen parameters, especially in the cases of severe oligozoospermia and azoospermia, that means the counts are very low or negligible, then you will think of getting an endocrine evaluation done. In case the patient is presenting with impaired sexual functions, and if in case there is findings suggestive of an endocrine disease such as a gynecomastia development or any other findings, then you can think of endocrine evaluation. Minimal, if you have to do just two tests, the recommended investigations are FSH and testosterone. These are a must to start with the evaluation. In case you have got a low testosterone report, the idea is to repeat testosterone, because the testosterone levels are highest in the morning, so you can't do them randomly at any point in the day. We can also think of doing SGBH, prolactin, LH, and E2. We can also think of doing inhibin levels, which are very, very, very important, but then the test is so expensive that usually we don't do it. So these tests are important, and how the reports vary. In case the spermatogenesis is normal, you have got normal FSH, normal LH, normal testosterone. Whereas in abnormal spermatogenesis, you have got a high FSH. Rest all hormones are normal. Important here is hypogonadotropic hypogonadism. This is a syndrome in which all the hormones are low. But the beauty is that it responds to medical treatment with the HCG and HMG. And nowadays, HCG is preferred because the treatment costs are lower and it's equally efficacious. In case the patient is presenting with the complete testicular failure, the hormone levels except testosterone, everything is raised. So these are the conditions which we need to explore, and we'll discuss them in detail when we come to azoospermia. Ultrasound is an important modality, and it's if you're doing a good physical examination, then the use of ultrasound is limited. But then in some conditions, such as a varicocele, must be confirmed with the help of a Doppler scan. Testicular volume, if you need a precise estimation, then you need to do a transscrotal scan. In CBAVD cases, or in which there is a blockade of vas difference, then we need to do a abdominal scan because the association is with renal anomalies. So you need to rule out the renal anomalies. In cases of obstruction, again, you have to do a transrectal ultrasound, but practically these are the few indications of doing an ultrasound. Otherwise, you can do without ultrasound also. Now, the genetics of male infertility. Genetics, the advantages of getting a genetic analysis is that it allays anxiety by giving us the correct diagnosis. It gives crucial genetic information which may affect offspring. Helps in choosing ART as an option, definitely with the counseling that the genetics of the future offspring may be affected. So when I talk of a genetic screening, and then we are looking at primarily, there is a plethora of investigations which we can think of in case of male infertile patients. But three investigations are primarily most important. One is the karyotype, second is Y chromosome microdeletions, the third is CFTR mutation. And third is the CFTR mutation. In cases of normal spermatogenesis, the karyotype anomalies are less than 1%. Y chromosome deletions are again close to 2%. CFTR is not identified. Severely impaired spermatogenesis, karyotype is 5%, Y chromosome microdeletions or YCMD is 7%. In case of non-obstructive azoospermia, again the karyotype increases. The most common karyotypic abnormality remains Klinefelter syndrome. YCMD is 16%, CFTR is not seen. Whereas in cases of obstructive azoospermia, karyotype is there is hard. It is as in the general population. YCMD again is not increased, but if you look at CFTR mutation, in 80% cases of CBAVD or congenital bilateral absence of vas difference, it is 80%, and C congenital unilateral absence of vas difference, it is 50%. In CBAVD, both the vas are absent, whereas in CUAVD, just one side vas is absent. So a chromosomal analysis is recommended in all cases of azoospermia, severe oligozoospermia, and when there is a family history of malformations, recurrent pregnancy loss, or there is a familial disorder. So whenever you're encountering a patient with sperm count less than 10 million, then there's a 10% higher risk of chromosomal structural anomaly, and you have to go in for a genetic analysis. Now a word about CBAVD. In this, the volume, it will ring an alarm when the volume is less than 1.5 ml, pH is less than 7, and the fructose is absent. We think of CBAVD. In men with bilateral CBAVD or bilateral vas absence, 65% are going to harbor a detectable CF mutation. In addition, 15% of these men will have renal malformations. Whereas in cases of unilateral absence, the incidence of CF mutation is much lower, but the incidence of renal agenesis is 40%. So that is the reason why we recommend a transabdominal ultrasound in cases of CUAVD. Now, if you encounter such a patient, then the right approach is that the genetic testing with CFTR mutations should be offered to the female partner of men with CBAVD before proceeding with treatment. Because in case the female partner is normal, then the chances of the offspring inheriting CFTR mutation is extremely low. So, and it's a very expensive test. So you should always rule out the female partner. Another the second most common cause of male infertility is varicocele, which is a condition in which the veins in the testes they dilate, and its evaluation includes medical and reproductive history and at least 2 semen analyses. It can present with low counts and high DNA fragmentation. Physical examination should be done in both recumbent and upright positions. It feels like a bag of worm which disappears when the patient is recumbent or lying down. When you perform a Valsalva maneuver, then the veins again dilate. Important point as per the American guidelines is that only large varicoceles, which are easily palpable, are known to be associated with infertility, whereas therefore scrotal ultrasound or Doppler ultrasound or any spermatic venography should not be used for the detection of subclinical varicoceles in patients without a palpable abnormality. In short, that large varicoceles are known to be associated with infertility, and ultrasound examination is not required. Whereas in case it is not palpable and it is subclinical and it is not bothering the patient is completely fine and the counts are okay, then there is no point in exploring it further. So the indications of treatment. The treatment for varicocele is varicocelectomy. It is done in cases when varicocele is palpable on physical examination. The couple has known infertility. Female is normal or has potentially treatable cause of infertility, and male has got abnormal semen parameters. When all these conditions are met, then we recommend a varicocelectomy surgery. Say no to varicocele repair when the sperm parameters are normal with clinically palpable varicocele, abnormal semen parameters with clinically non-palpable varicocele. So if the semen is normal but the varicocele is there, don't go for a varicocele repair. If the counts are abnormal but it is again non-palpable, so you can still manage without varicocelectomy, because there are other means of retrieving the sperm, which are the surgical sperm retrieval techniques. So you can use them and retrieve the sperm instead of repairing the varicocele first and then waiting for 6 to 7 months for the sperm parameters to reverse. Azoospermia with varicocele, if the patient has got zero counts and he is presenting with varicocele, then again varicocele repair is not going to bring sperm in his ejaculate. Then again you might have to go for a surgical sperm retrieval, in which you retrieve the sperm directly from testes. And when you retrieve the sperm directly from testes, it is a much healthier sperm. We'll again discuss this point later on. IVF is indicated in couples with the aim to improve semen parameters for IVF standards. When there are people who will recommend that this varicocele surgery will bring your semen counts to normal levels. Generally, we have observed patients over 18 months, and after varicocelectomy, the counts will reverse in only a few patients. So, if your primary intention is to get a baby, then ART is the method of choice rather than getting a varicocelectomy done and then waiting for another 18 months, because the age is also very crucial in reproductive sciences. Leukocytospermia, or when there are more than 1 million pus cells seen in patient's semen sample. If more than 1 million leukocytes are seen, then the person has to be treated, because leukocytes are a source of reactive oxygen species and free radicals, which can lead to DNA fragmentation and reduce sperm motility. Generally, the antibiotics used are doxycycline, quinolones, mecacin, azithromycin. And the important point here is that the antibiotic therapy has to be combined with antioxidant therapy to take care of the ROS damage or the free radical damage. Otherwise, the infection may be cured, but the DNA damage will not reverse. Immunological infertility. This is something which is a little technical, so we will leave it in this. In short, what I like to say is that the anti-sperm antibodies develop in the body, and which help in which actually decrease the sperm motility. The treatment is with steroids, which has shown a mild increase in pregnancy rates. With obviously, you can simply do a IUI in such patients, in which sperm washing takes care of the antibodies and improves results. Again, coming back to a topic which we wanted to discuss since the beginning, that is sperm DNA fragmentation index. It is not a routine test, but it is gaining popularity. It is a test which helps in measuring the quantity of or the proportion of damaged sperm DNA, and this sperm DNA generally cannot be repaired. There are 4 techniques which this is important for you to understand, because a lot of people are doing tests which are actually not recommended, and they are simply money minting tests. So the tests which are offered are COMET test, tunnel test, SCSA, and SCD. So in this, the gold standard is COMET and tunnel and SCSA. I mean, tunnel and SCSA are the gold standard. COMET is not offered at many places in our country, whereas a sperm chromatin dispersion test, it is being offered in all the labs, but it doesn't give correct information. There are no cutoff which have been established. There is a lot of subjectivity. So please, when you are going for a DNA fragmentation evaluation, go for a 1 second, please. Lecture. I'm sorry, there was some distraction.
No problem.
Yeah. So when you consider the top 3 tests, COMET, tunnel, and SCSA, the thresholds for them are SCSA, it is 25%, tunnel test 36%. The most commonly studied test is SCSA. So what various labs are doing even for SCD, they are using the SCSA cutoff values, which is not recommended and which is not advisable. So please go for better test, because test is expensive. It can give you valuable information if it is done correctly. So how much is normal? In case you're talking of SCSA test, if it is less than 15%, it is very good. If it is 15 to 30%, it is good. It is fair. But in case it is more than 30%, it is poor. So what are the indications of a DNA fragmentation? It is done in cases of unexplained infertility, arrested embryonic development, and poor blastocyst development. Blastocyst is a day 5 embryo, which is, if it doesn't develop, then you can think of the final DNA damage. In case there is a multiple failed IVF and ICSI, then you think of a DNA damage. Recurrent miscarriage, recurrent implantation, advancing age. We have spoken about age a couple of times in this lecture. Varicocele again is something which will raise the temperature of the scrotum and it will bring on DNA damage. In case there are poor semen parameters, occupational hazards, person is a radiotherapist or a radiology technician or a radiologist. If the exposure to chemicals, he's working, he's in the process of construction, and also he's exposed to chemicals, he's working in a chemical factory. So these kind of patients, we have to think of doing a DNA fragmentation test, which can determine the chances of conception. Look at this graph, which says that live birth after IUI is 19% in normal patients, whereas in case the DNA is elevated, it is almost 1.5%. So in such patients, you will not go for a IUI. You will directly jump to IVF or preferably ICSI. So if you compare IVF and ICSI results in sperm people with high sperm DNA fragmentation, then ICSI gives you the best results, around 42% compared to IVF. How can we minimize DFI? You have to stop smoking. You have to cut down on your weight, alcohol, stress. You have to start yoga and exercising. It helps in minimizing the DNA damage. When you talk of treatment other than lifestyle, we can have antioxidants. Antioxidants also, if you look at, there are many cocktails which are available in the market, which will go on adding all sorts of antioxidants available in the market in minute doses. They don't work. Simply go for vitamin E 800 milligrams or vitamin C 1 gram per day. This dose is essential and it is most effective. Many studies have shown. There are other combinations, but all the combinations should have minimum of these doses to be effective. A varicocele repair may reverse DNA damage if it is because of the veins dilating and increasing the temperature of the scrotum. Testicular sperm is always better than ejaculate. In cases of high DFI, more than 30% or more than 60% precisely, testicular sperm is recommended. But again, this is a surgical procedure, so it has its own pros and cons. So you talk to the patient and then make him understand and let him choose which method he wants to go for. There are lab methods which can take care of DFI, such as microfluidics, double density wash, etc. In case we have established that the patient has high DFI, then we recommend the patient for frequent ejaculation before his IVF treatment. And especially at times we will ask him for a second sample on the day of pickup with just a gap of 1 hour. And it is seen that short abstinence decreases sperm DNA fragmentation. So at an abstinence of 1 to 2 hours, we have got better results, and we actually have used this established fact to our benefit many times. Again, azoospermia is complete absence of sperm. It is seen in 10 to 15% of infertile men. Obstructive, in which it is a post-testicular obstruction. It is 1/3 cases. And non-obstructive azoospermia, it is testicular and pre-testicular. It is seen in 2/3 of the cases. Fortunately, there are focal areas of somatogenesis which are seen in non-obstructive cases. So non-obstructive is when there is a testicular pathology or a pre-testicular pathology, whereas obstructive is post-testicular, when the sperm is formed in the testis, but it is not able to go through the duct and be present in the ejaculate. In pre-testicular, we can have congenital syndromes. Whereas testicular, we have congenital and Sertoli cell syndrome. In this, Y chromosome microdeletions play a role. In acquired, we have a trauma to the testes or a testicular tumor, which might just bring down spermatogenesis. Obstructive cases, we have got congenital CBAVD, or acquired, it is vasectomy. To diagnose azoospermia, it is not a single shot diagnosis. It is better to do semen analysis thrice over 6 months period, at least thrice over 6 months period. even not only doctors, even the patients do not have such persistence nowadays. So everybody wants a quick treatment. So we have hardly been able to evaluate any patient 3 times over 6 months. They come with their own timelines, and they're not willing to listen that they don't allow us to follow the correct protocol. Very few of them will understand and you know uh, like to benefit, because at times one patient may be azoospermic. On one occasion he might just give us sperm, which being a decent ART center, we are able to freeze that semen and we are able to use it for our ICSI procedure. Biopsy, when you're doing a testicular biopsy, it's recommended in cases of azoospermia. You can have a variety of results, such as you can have a normal spermatogenesis seen, lower than normal spermatogenesis. It can be a maturation arrest, it can be a Sertoli syndrome. You can only see down spermatids. So various findings can be seen. But the important point which I'm trying to make here is testicular biopsy should be done at a place which has the facility of sperm cryopreservation. Just in case you happen to find the sperm, it has to be preserved there and then in the same center. Otherwise, if you don't freeze it at the same place, then you have to go for another round of testicular biopsy or testicular aspiration, which every time you are doing a testicular aspiration or a biopsy, there is some degree of hemorrhage, something happen, some fibrosis happens in the testis, and that area of spermatogenic activity is obliterated. So every time you're losing on valuable tissue. So do it once and freeze it. The tissue should be good enough to support at least 3 IVF cycles. So there is no role of a trial TISA unless if you have a cryopreservation facility available. Sperm retrieval techniques, which I was discussing many a times, surgical sperm retrieval techniques. These are recommended in cases of obstructive and non-obstructive azoospermia. Obstructive is when there is a problem with the duct system. Non-obstructive is, as I told you, it is either a testicular or a pre-testicular reason for it. So you can take let me show you some figures. In cases of obstructive azoospermia, you can we can use a BD syringe or a small syringe, a hypodermic needle, and we can directly enter the epididymis and aspirate the seminal fluid from there. Or else we can go in the testis and aspirate the seminiferous tubules. Then there is a procedure by which we can separate sperm from the testicular tissue and use the sperm for ICSI. And this is a testicular biopsy, a picture of testicular biopsy, in which you cut open the testis and take a small tissue, tease it, and then separate the sperm from the tissue. And again, it can be used for ICSI. Micro-TISA is the latest technique in which the process of testicular biopsy, it is done under a high magnification, and the testicular tissue is examined under the microscope. So even if there are few areas where sperm is being formed, that area is identified, and preferably we take the tissue from that area. So this has actually improved pregnancy rates in people with very small testes. Even less than 10 cc, 10 ml testes have been shown to give results in patients with Klinefelter syndrome, undescended testes, torsion of testes, Sertoli syndrome. These are all technical terms, but the point I'm trying to make is that even in very difficult cases, this technique has worked. But this is a very expert surgery, and you need a properly trained person to carry out such a procedure. A general urologist may not be able to do justice with this micro-TISA technique. So, and it's a very expensive technique. So go to the right place and go to the right person. Medical treatment, as I discussed, is indicated in hypogonadotrophic hypogonadism. In hyperprolactinoma, you will give dopamine agonist, whereas in hypo cases, we will start with the HCG injections, 2,000 to 5,000 international units 3 times per week, and we'll give it for at least 3 months, and then check for semen analysis again. And depending on if there is any spermatogenic activity which has been stimulated, then you either continue with HCG or you can add HMG. HCG generally is much cheaper. For erectile dysfunction, we generally start with sildenafil or its analogs. Generally, we start with low doses, 25 milligram, 1 hour before intercourse. And in case the patient is not getting any benefit, we can increase the dose. Retrograde ejaculation, well, we told you the processing of retrograde ejaculation and how the sperm is going in the bladder. In this, we can use drugs such as pseudoephedrine and ephedrine combined with IVF, IUI, and ICSI. In leukocytospersmia, in this, there are leukocytes or pus cells present. We have to give antibiotics as well as antioxidants. Idiopathic male infertility, we can give androgen therapy and exogenous FSH, clomiphene citrate. They have been shown to work in some cases and improve sperm counts, but generally it's a gray area. Surgical treatment in cases of CBABD, we can go for a vasotomy in which the vas is joined to the two ends of a vas are joined, or vas can be directly joined with the epididymis. We can resect ejaculatory ducts, turate when the ejaculatory ducts are obstructing. Varicocele can be repaired in case the patient opts for a varicocele repair. Generally, infertile patients, they go for ART procedure and they don't invest their time and money in varicocele repair. Orchopexy is done in cases of undescended testes. This is also important. Drugs that impair male infertility. Patients on these drugs should be counseled that their fertility and their habits may be affected because of the intake of these drugs. Impaired spermatogenesis can be seen with sulfasalazine, methotrexate, and NFT, etc. Anti-androgenic effects are seen with spironolactone, cimetidine. Ejaculatory failures is if the patient is on alpha blockers, then he can have ejaculatory failure. Erectile dysfunction is common with beta blockers, thiazide and metoclopramide. So last year we did a small study on this device, and this is a small chip in which you can put a drop of your semen, and then you can connect it to your mobile camera, and it gives you your concentration and motility. And we found that this device is reasonably, it reasonably matches or gives you some idea. In the normal cases, at least, it gives you a fair idea of, but in abnormal cases, this doesn't work that well. Thank you so much, and I would be happy to take any questions.
Thank you, sir. It was a wonderful presentation. We have a lot of questions in the chat box, so I'll say out loud.
Okay. Can I see the questions? Yeah.
It's in the chat box, sir. You can definitely click on it.
Yeah, please.
Yeah. So I'm going from top to bottom. So Ramanaji has a question. Is teratozoospermia curable with medicines, and how much time it may take to cure? Comments from doctor was amorphous head, ovulated head, short head, round head plus cell is 3.4 by HPF, RBC is nil. So
in this patient, you have to cure the infection first, because we're seeing pus cells 3 to 4 per high power field is a lot of pus cells. So you have to cure the infection first, and that will have a positive effect on the DNA fragmentation index as well as teratozoospermia. And there are a lot of precautions. I'm sorry, I wanted to show what precautions should be taken to improve the quality of sperm. That is primarily the morphology. It doesn't affect what you say is the quantity of sperm or the concentration, but it definitely improves the quality. But we can share that slide later on. I can share it with you, and you can pass it on to the person asking the question. Actually,
yes, we have Miss Sunitha. She is saying that her count is 12 millions per ml, motility 60%, morphology is normal, forms 2%, teratozoospermic index 2.6. Wife had 4 miscarriages without heartbeat of fetus. Wife has hypothyroidism and PCOD. Chromosome report is normal for both. APLA profile is normal for wife. These 4 pregnancies happen with normal intercourse. Our miscarriages can happen due to defect of sperm fertilizing the egg, or can defected sperm fertilize egg? Is IUI an option?
no, I think the concern here is the teratozoospermic index, which is 2.6, rather 2.66. So in case the TZI is more than 1.8, we generally recommend ICSI for such patients. So the miscarriages can be due to a sperm factor in this patient. But wife hypothyroidism, I think she must be taking medicines. Karyotype is normal. Alpha profile is normal for wife. So I think IUI, not IUI, but they have to go for a proper ART, or else what they can do is they can get a semen morphology done in a prepared sample. I mean, first wash the sample and then get a morphology done. If the TZI decreases to close to 1.5, 1.6, then they can go ahead with IUI. Otherwise, they have to go for ART.
Okay. We have another question by Ms. Aruna. How frequently do you observe Y chromosome microdeletions?
I will say not very frequently, and generally what we see is AZF-C deletions in which we are able to find sperm. But at times we do encounter AZF-A and B deletions also, and we can at times we see that C is also seen and B is also seen. So in such patients, the chances of retrieval are become very low. But yes, these deletions are seen. They are not very common, but they are seen. I've shown the percentage also in my slides. So 5 to 10% infertile or azoospermic patients, we do see YCMT.
Okay, sir. We have another question by Mr. Atul. Is there any relation between obesity and semen count? You've already covered it, but if you would want to say anything.
Obesity actually it decreases counts, because one thing is that it will raise the scrotal temperature because of the lot of flesh around the thighs, and also it will increase the temperature, as well as the sex banding globulin is also increase. And so I've shown in the slide that with every 4-5% increase in BMI, the counts and the volume also decreases by I don't know, I don't recall what was the percentage, but then we can always refer to it. So the weight reduction is something which has to be done. Exercise and all, it will go down, bring down the DFI also, and the counts might improve.
Okay, sir. We have another question by Ms. Kritika. If prolactin is high in both male and female, are there any chances to conceive?
Yeah, we can. This can be medically managed. I did show you the hyperprolactinemia can be corrected with the dopamine agonist, and so there is definitely a chance to conceive. I mean, and then we have to look at the other hormones also, like FSH, LH, and so then only we can comment precisely.
Okay, sir. We have another question by Ms. Kritika again. What is andropause? Does it have a particular age like menopause?
So it is generally seen in men more than around 50 years of age, and when the testosterone levels go down, and men become irritable because of loss of erection and ejaculatory disorders, and a lot of mood swings are seen. So it is something similar to menopause, but it may not be as common.
Yes, not many have heard about it.
Yeah,
Menopause is
it's an
something that we do hear commonly.
emerging term. I also heard it around 5 years ago. So
We have a question by Mr. Shodra. Is sperm freezing an option for males requiring chemotherapy for cancer treatment? How successful is the revival of a sperm post-thawing and leading to conception through IVF procedures?
see, we are routinely doing freezing, but then it depends on what the counts are. Actually, it depends on what the counts are before before freezing. And because there is some degree of 20 to 30% loss of count and motility when we thaw them post freezing. So if the counts are already compromised, which generally in many cases the counts are compromised in patients suffering from cancer, even before the start of chemotherapy. So we have been trying to counsel the oncologists that they have to send the patient early to us. I mean, we can't accept. There is no point in sending the patient after two cycles of chemotherapy or radiotherapy, because the sperm anyway would have decreased by then.
Okay, can this be revived like after the chemo is
Yeah,
finished?
yes,
It
after the
repair
chemo,
itself.
mitogenesis does reverse, but then it depends what drugs are given. In
All
some
right.
drugs such as cyclophosphamide, etc., the chances of reversal are less.
We have another question by her. For a male patient who has a Y chromosome microdeletion, what options can be suggested? for pregnancy?
See, if it is a C deletion, then there is nothing much to worry. Surgically, sperm can be retrieved. Even in cases of Y chromosome A, YCMD, AZF-A deletions, there is a high probability of finding sperm, but then you have to go for a microtessay. But A and B both are poor chances of finding sperm. But yes, with an expert urologist who is doing microtessas quite frequently, the chances increase.
Okay.
That microtessay is the last option for such patients.
Dr. Deepika has a question. What is the average male fertility problem in India, and how many of them are curable? I think she's asking about the stats.
15% is the infertility problem. Out of them, around 40 to 60% there is male contribution, and in generally 10 to 15% are azoospermic in them. Rest, or even a big fraction of azoospermia can also be cured. And besides azoospermia, many patients can be cured. But generally, what we are saying is that there is a big chunk of patients in which the male as well as the female has some issue. Around 40% of the patients in which you cannot, ascribe the infertility to only male or only female. There is a combination of a couples having both male and female having some issue. In those patients, you cannot guarantee if you can take care of the male factor, but you cannot take care of the female factor. So the overall pregnancy rates in infertile couples, they range from 35 to 40% only.
Okay. We have a question. What can be suggested for a male patient who is diagnosed with oligoasthenospermia? Is IVF the only option for such couples?
See, it's a tricky question. Oligoastheno, and then till the time we don't have the precise counts, it's difficult for us to comment actually. But generally, IVF and or ART assisted reproduction techniques work well in such cases.
Okay.
If it is severe oligoasthenospermia SOAT, then ICSI is the only option. But in OAAT, IVF may also work, or IUI may also work. I showed you a chart in which we have prescribed the cutoffs that 10 million you can go for IUI, 5 million you can go for IVF, 1 million you have to go for ICSI.
Yes. Then we have a question. Does intercourse during menstrual cycle leads to pregnancy?
No, that's not possible.
Then we have a question by Miss Pooja Patel. Hi sir, my husband's sperm counts are 4 million, so is ICSI the best for infertility?
4 million, yeah, I think the motility has to be, she's not commented on the motility, Pooja, but generally ICSI is 4 million, I think ICSI will be a fair option. But we need to look at the motile and the volume also. But practically ICSI is going to work for her.
Okay. We have a question by Miss Vaishnavi. If a male has polymorphic variant in either an autosome or on the Y chromosome, YQH plus or YQH minus, what is an ideal option? Donor sperm or one cycle of IVF along with PGT?
Polymorphic variant in either an autosome or Y chromosome. I'm sorry, this is a pure genetics question, so I need to refer to, maybe you can answer or Ashish can answer this question.
Yeah, Vaishnavi, you can mail us personally. We'll answer your question. Then we have another question by Mr. Arun. Does excessive masturbation in childhood cause erectile dysfunction?
No, it's all. There is no scientific proof supporting this.
Okay. And one more question we have. My question is, Kritika is saying that my question is, the test tube babies are also in risk of fertility at a later age?
Sorry, can you come again?
Is a test tube baby also in risk of getting infertility at a later age?
Definitely. I mean, infertility can happen to anybody. But if we have established that there are Y chromosome microdeletions present, then obviously the male offspring will present with low counts or azoospermia, and then obviously he will require some kind of assisted reproduction to have a family.
Okay. So
it is not the bottom line. It may or it may not.
Yes. So the last question that we have is, can a male diagnosed with hypogonadotrophic hypogonadism have a child? Is there any
Yeah,
specific
yeah,
treatment
yeah.
suggested for such
No,
individuals?
hypogonadotrophic hypogonadism can be medically managed very nicely. I have told also in my slides.
Yes.
So this is something which can be managed through medical treatment, and these are the patients with very good prognosis actually.
Yes. And we have some more questions. What is the normal longevity of spermatozoa in female genital tract?
It is around 48 to 72 hours.
Okay. And Dr. Nitin wants to know what is normal longevity. Okay, this is the same question. Yeah. Naveen wants to know, does IUI work for teratozoospermia?
Yeah, IUI does work.
Okay. Yes, I think
Because
we have covered most of the questions.
we have to take into account the count, motility, volume, and
Yes.
morphology. So everything together it might work. So if all the other three factors are favorable, so they can take care of teratospermia.
Yes. I think most of the questions we have covered now. If there are any, you can please mail us personally. All right, sir.
Thank
I
you.
think we'll end the webinar. Thank you for taking out your time. It was very informative session.
Thank you so much.
Thank you, sir. Thank you for being with us. And I thank all the guests. Please keep yourself tuned for the upcoming webinars.
Yeah, thank you. Thank you, Shrinki.
Thank you, sir.
So can I log out now?
Yes, sir. I am just ending the webinar now. Thank you,
Thank
everyone.
you. Thank you.